everyone, and welcome back to another insightful episode of MedSynapse podcast series. Today, we're diving into one of the most critical and complex topics in the recent medical history, which is COVID 19 and its autoimmune implications, a phenomena often referred to as the COVID storm. And we're thrilled to have with us Dr. Phillip Anthony with Dr. Phillip is a leading physician, autoimmune researcher, and dementia expert who was the first to propose the groundbreaking theory of autoimmunity involving ACE2 during the early days of the pandemic. His pioneering work has significantly advanced our understanding of how COVID 19 interacts with the body's immune system, causing severe complications in some patients. Beyond COVID 19, doctors' research into dementia has been transformative, and today we're excited to explore his insights on COVID storm. So, welcome, Doctor. It is a pleasure to have you here.
Thank you very much. Really appreciate it.
So, let's just get started, Doctor. So, you have had such an incredible journey from being a practicing physician to becoming a leading researcher in both COVID 19 and autoimmune diseases. So, could you briefly walk us through your journey and what led you to this pivotal point in your career where you proposed such an important theory?
Yes, it can be confusing to people because when I talk about my dementia work, they're thinking, what in the world is the connection with COVID? Well, it was very simply just that I'd spent 10 years doing what I describe as clinical research. I analyze research and try and put it into a clinical context. I'd been doing that on dementia over that period of time, and I use a specific strategy for how I did research. And that was the point that led me to the point where right before COVID, I was just about to propose the full mechanism of dementia and explain many of the characteristics. Then COVID hit. And my question was, why not apply the same principles of research to COVID? Because if I could use those techniques in dementia, because it doesn't matter what disease it is, I can apply the same principles to any disease. And in time, you will get close, if not identify, what I call primary pathophysiology, root cause disease. So I then applied that principle in early 2020. And by April of 2020, I saw what was clear based on the characteristics of the research that the severe disease was a viral mediated autoimmune response that triggered a cytokine storm. And so that then made me realize that our approach, therefore, to the disease needs to be different than it was. So it's no longer just about antivirals, not that they can't help, but you need to dampen down the immune response. And when we look at the drugs that have been used, the steroids, the tumor necrosis factor blocking drugs that are first line almost for severe COVID, it makes perfect sense. It's just that that understanding has not yet been fully embraced by the scientific community.
I think that is so interesting and fascinating to know that, your entire journey and also your work in dementia, how it paved the way for understanding COVID 19 is in such a profound way. Now, you have introduced this breaking concept about COVID, how COVID actually triggers autoimmune responses. So, for our listeners, can you explain how the virus triggers these autoimmune responses in the body? And are there any specific populations that are more vulnerable to these autoimmune complications?
So I think it's important to look at where we are now and reflect on where we were before. So when we had the first phase of the pandemic, or the first and second, even up to the Delta wave, the main response there that we had proposed, which the evidence has come out that our proposal was correct. It doesn't mean that people accept that as the primary pathophysiology, but all we said was that in people who have elevated levels of free floating ACE2, the same receptor that the virus uses to get into cells, that when the virus gets into the bloodstream, if those free floating ACE2 proteins attach onto the virus, the immune system can then, in its overreaction, make autoantibodies, not just antibodies to the spike protein, but antibodies to ACE2. Now, we wanted to do that research in 2020, but we didn't get the funding. It was shown in October 2020 that this did happen, and it was really confirmed in 2024. So earlier this year, they did the detailed study showing, yes, ACE2 autoantibodies are present. And that's important because ACE2 autoantibodies are not typically part of any other disease. So it's very significant that it could almost be used as a marker for severe COVID-19 because it's so unusual in any other disease. So that is where we were. The question is, where are we now? And so when you understand that the only reason you get that characteristic with severe disease is because the immune system hasn't been exposed to the spike protein, now the whole world has been exposed, but the virus is still circulating. So what are the implications with further exposure of the immune system to spike protein? That's where we are now, and that's the bit that really requires very careful thinking. So in the same way, in 2020, I proposed autoimmunity to ACE2. I am now describing another kind of disease, which I describe as STORM, spike-triggered autoimmune response mechanism. And that's about what happens to the immune system when it is re-exposed on multiple occasions with reinfections. How does that lead to new disease pathways? That's where I think we need to catch up. So one of the problems is if people didn't understand autoimmunity in the first place, it's almost impossible for them to understand where we are now and what are the implications going forward.
Yes, actually, that is so rightly mentioned. And also, I feel that the connection between virus, spike protein, and ACE2 is so critical to understand how actually the body responds. And now that actually brings to a related phenomena we all have recently heard about this, which is cytokine storm. So could you explain what exactly is cytokine storm and how it plays into these severe COVID-19 cases?
So when we go back to understanding the mechanism of that cytokine storm, it's still almost a process of research, but I can tell you what we understand up until this point. There are some very important things about this virus that is different from other typical viruses. The most important thing is that it is exceptionally good at suppressing an interferon response. What that means is when you get an infection, the cell that is infected produces a small cytokine or protein called interferon. It signals to other cells and the immune system that there's a viral infection. And it represents almost a warning signal. It's like the lights flashing in the building. Everybody knows there's a burglar present. But SARS-CoV-2 is able to evade interferon exceptionally well. This is why so many people don't have symptoms but are infected. If you remember, people were getting swabbed, they found they were positive, and they said, I had no symptoms. That's because the virus is so good at blocking interferon. Now, what happens is that when the virus then spreads to the lungs, okay, and unless you were able to block the infection at the nasal passages, it would spread to the lungs. That's when people would get that interferon response. And some people would go, oh, I'm feeling a little bit unwell. I have a cough, I have a little bit of a fever. And then that's it. And then it goes away. Now, it's important to note that when people had those symptoms, if you were to do a scan of their chest, there was significant inflammation from the viral infection. It's just that because the interferon suppression was so good, they didn't necessarily have symptoms that correlated with the degree of inflammation. Very important understanding. So now we come to the cohort who had severe COVID-19, because at that point, that's just viral infection, viral inflammation. You could call it a viral pneumonia. But the cytokine storm is a different ball game. That's where we come into the autoimmune response. What we predicted happened is that when we had the virus spreading to the lungs without any signals, with almost any virus that you do that, if you take a flu virus and you nebulize it and it goes into the lungs without a warning, there is always an overreaction. And so you have a massive interferon response, lots of immune cells coming in. And so that inflammatory process is where we think that you have the trapping of free ACE2 with the viral spike protein, and that massive inflammatory response triggers the autoimmunity. For those who are clinical, they will realize that there is oftentimes about a 7 to 10 day delay between somebody being infected and somebody going into hospital. That suggests it's not the virus that causes that. The cytokine storm then is the immune system responding to it. And when the immune system responds with its IgG antibodies and you have this autoimmune process targeting ACE2, that's what leads to the cytokine storm, which damages the blood vessels in the lungs especially, causes them to make little clots, and it's these microclots with the viral inflammation that causes people to die. That's the essence of what I describe as that viral triggered autoimmune response mechanism we call a cytokine storm.
Yes, that was really interesting explanation, and it's actually like the body's immune system goes in overdrive and then causing damage instead of protecting the patient.
Absolutely.
Yeah, right. So now, given that autoimmune responses are central to this, I'm also so curious about your thoughts on vaccination strategies. So we know that vaccines have been critical in fighting the pandemic, but are there risks of triggering autoimmune responses post-vaccination, especially in vulnerable populations?
So part of the challenge that we had was that the scientific community didn't understand the concept of autoimmunity when vaccines were being rolled out. That creates a problem because I knew that you needed to be cautious. It's not that you didn't use vaccines, but you needed to think carefully about that risk-benefit equation. So in my view, what should have happened is that we do what is called targeted vaccination. If somebody had already been exposed to the virus and had infection from the virus and already had moderate to severe COVID-19, therefore meaning they had autoimmune responses, you shouldn't then put more spike protein in them. If somebody had previously been exposed to infection and they had gotten past it, it would suggest that they should have normal interferon production when they were exposed again, and therefore they wouldn't need to have a vaccine. But if someone had not been exposed and was in the high risk category with elevated levels of ACE2, who we knew who they were older, they were obese, they had diabetes, they had hypertension, they had heart disease, they had kidney disease. That cohort, based on the limited information we had, would have been very reasonable to accept the risk about vaccinating them when we didn't fully understand all that was happening and we thought that the vaccine could trigger long-term immunity.
So now I think that was such an interesting point, balancing the benefits of vaccines with the need for extra caution in certain population. So now, speaking of complexities, there were a lot of complexities with COVID. So, as someone who has deeply been involved in research throughout this pandemic, so what do you think the COVID storm reveals about our global preparedness for the future pandemics?
Well, for one, I think that now that I have looked at it and reflected on it, I realize that most of the conditions that we are afraid of, say for instance, Ebola, Marburg virus, even dengue hemorrhagic fever, the more you look at it, the more you realize that what COVID has done is that it has exposed where we need to focus our attention. I suspect for all of these infections, they are triggering the immune system to overreact. So therefore triggering the autoimmune. So it's not the virus that is necessarily killing someone, but the immune system's response to the virus. If we can find mechanisms that dampen that and keep that in check, we would be in a very good place to try and protect against further injury. Now, the problem is that in order to have pandemic preparedness, because we are limited in our thinking, we suspect that the only way you can do that is through vaccination. I would say that we need to be cautious. Vaccines work, but they don't work for all viruses. A good example would be dengue fever. Dengue fever is very difficult to vaccinate against because if you get exposed to the wrong virus and you have primed the immune system to the original virus, it's that causes the overreaction. And so in some viral infections, your approach may need to be different. The lesson that I think we have to reflect on from COVID is assuming that one strategy fits all. It doesn't. We need to be far more nuanced when we're thinking about further pandemics and the risks to the population. Additionally, if we are thinking of further pandemics, it is exceptionally important that everybody who is in the scientific community goes back to the original question as to where did the virus originate from. If it is coming from a lab, that's gain of function research. Gain of function research is still occurring across the world. And what we should be doing as a scientific community is calling for a moratorium on any further gain of function research that involves viruses, because it could really put the whole world at risk.
Yes, I think that is so crucial points that you have raised, and especially about the preparedness of something if something might happen in the future as well. Now, for my next question, what would be the biggest gaps in COVID-19 research today, especially in relation to autoimmune responses? Where do you think future research efforts should focus on?
Well, the difficulty with autoimmunity is that autoimmunity can only truthfully be fully understood with histological examination of tissue. And what has been the biggest failure in the pandemic is the fact that we haven't been doing enough autopsies. Without autopsies, we are blind. We're flying blind. So what we should be doing is that we should be regularly, anytime there is a patient who dies from either COVID or even any unusual patterns, we need to be doing autopsies and histological examination of their tissue. That's where we will see patterns that will explain to us what it is that is happening now. One of the big mistakes is that much of the scientific community and the medical community thinks that when the pandemic is over, we go back to standard practice. No, we can't. The pandemic has fundamentally changed the physiology and pathology of the whole world. In order to understand it, we have to almost start from scratch. And what I say to people is that from this point on, The question for every specialist is, if you are a neurologist, it's how has COVID changed the neurology and the pathology associated? It's same for cardiology, same for renal disease, so for all diseases, we now almost have to have a separate box that is to do with COVID-related changes of the pathology. How does it impact our treatment and our understanding of disease?
Absolutely, that is so rightly mentioned. And also, there was something called as pre-COVID phase and the post-COVID phase. So that is, I think, sometimes for real. And but now, after 4 years, a lot of things have again come to normal. Some strategies need to go back, I feel. So I think there's so much more to uncover, and your work is clearly lighting the path, Doctor. And this conversation has been an eye opening for me, at least, and I'm sure it will be for our listeners as well. So, but before we wrap up, I just want to say thank you once again, Doctor, for sharing your time and insights with us. And is there anything else you'd like to share with our audience before we wrap up?
If I'm speaking to clinicians and scientists, one of the important lessons that I would like to put across is the fact that I could look at COVID, even not being an infectious disease specialist. I didn't have to be a respiratory specialist. I didn't have to be a virologist. I just had to have an attention to detail and an understanding as to how to approach research. For many clinicians, they don't do research and it's left to academic institutions. The problem is that clinical people, when they're seeing patients on the ground in front of them, have a much better insight into how disease presents and how we can look at transitions of disease. From this point on, everybody needs to go back to the basics of doing their research. There are so many layers that have to be analyzed now that it will require the whole medical community to be regularly looking, discussing, analyzing, and if that's not done, we have no chance to protect patients in the longer term. It can only come from clinicians. The academic institutions, the pharmaceutical industry will never find these answers. And the responsibility of physicians and doctors is to advocate for their patients and to make sure that they have adequate information to understand that process.
Absolutely, that was such a lovely piece of advice for all the clinicians out there, Doctor. Thank you so much, and it has been a privilege talking to you about this important topic today.
Thank you.
For our listeners, thank you for tuning into this episode of MedSynapse podcast series. And remember, if you're a healthcare professional who is eager to delve deeper into medical topics or have questions, do not hesitate to join us on the MedSynapse platform. MedSynapse platform is not just a resource; it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until next time, stay aware and take care of your health. Thank you.